You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 28, 2023, and our topic is chronic urticaria, or hives. Our presenters are yours truly, Dr. J. Portnoy and Dr. Aarti Pandya. We're in the section of Allergy, Asthma, and Immunology at Children's Mercy Hospital in Kansas City, Missouri.
Let me do the brief introduction, and thanks for everyone for being here today. Good morning. I'm Chris Miller, coming to you on Conferences Online in Allergy from Kansas City. Today, on July 28th, our two speakers, like we have in the last few weeks, actually, are Dr. J. Portnoy and Dr. Aarti Pandya. They're doing what's called the orientation series. This is I believe, the last of the 8 that they have given here. These are just some quick topics to get you up to speed. And then starting next Monday, we're going to go into quite a variety of different speakers throughout the rest of the summer series. Today, we'll be talking, our first presentation will be on urticaria, and the second one will be on telemedicine. And with that, thank you for being here today.
There you go. And as you said before, these aren't practice parameters, these are practical parameters. So we're trying to make them practical. I'm not showing a lot of studies or any of that stuff. It's really just when you're in the clinic, how do you do the stuff that you need to do? And it's just kind of expert opinion more than anything else. Let me pull up my slides. Okay, I've got to share my slides. Okay, can you see my slides?
Yeah, we can see them.
Okay, and I'm going to just start it as a slideshow. So welcome to our last 2 episodes, if you will, installments in our orientation series for 2023. And today we're going to talk about urticaria and angioedema. We've tried to choose topics that are very common in the clinic. I think everybody sees these things frequently, so it's important to get started right off the bat with those. I'm Dr. Portnoy, and I'm co-presenting with Dr. Pandya. And these are our disclosures. None of them are relevant to urticaria. These are the learning objectives. And this is the obligatory slide. If you're going to talk about hives, you have to have this slide just because it's tradition. Okay. So would you like to talk about the typical history of hives, Dr. Pandya?
Absolutely. So I'll read through these cases and the case here, and then we'll kind of talk about some of the salient features that we need to identify via history when we are taking a history on hives. So here we have a 4-year-old who developed an itchy rash about 6 months ago. It lasted a few days and then went away. Mom shows you a picture of it on her cell phone. 2 months ago, the rash came back and lasted about a week. The patient had eaten a piece of pepperoni pizza a few hours prior to the rash, and he's avoided pizza since then. Last week, the rash came back and lasted a few days leading to this visit. The parents want to know what food is causing the rash. This is generally a very typical history that kind of comes up, in individuals who've had intermittent episodes like this. When someone, comes to you with this complaint, they're going to potentially just say hives or say, whatever rash term that they have already learned right off the bat. So it's important to kind of make sure that you get good characteristics of that taken, meaning, what kind of lesions are they? How long are they lasting? All the characteristics. Are they raised? Are they flat? Are they associated with pruritus? How long do they last? And then upon resolution, do they leave discoloration? Those are some salient features right off the bat that you are going to want to know when you get a history like this. And so, but this is like a good typical case scenario that we see in the clinic when we have hive evaluation.
See it all the time. And it's very common for parents to show you a picture on their cell phone. If they even if you don't need them to show it, you kind of know what's going on. Look at it anyway. They're so proud of the fact that they took a picture and they really want to show it to you. So look at the picture. Also, They always assume that it's a food. I don't know why food is the cause of all rashes, but it's always a food. And in some cases, they stop eating the food, even though they were eating it before without a problem. So it's something to just to be aware of.
Mhm.
Here's another one. This is a 5-year-old with a 3-day history of this rash. Rash is very itchy, worse in the afternoon, lasts a few hours, then goes away. Has not eaten any new foods and has not changed any soaps or laundry detergents. What is this, Dr. Pandya?
Um, and then this could also, be a history of urticaria. However, if we contrast the two cases, notice that this one is, present for a 3-day time period, and the case from before had episodes that lasted for a week over the course of many months. So
Yeah.
we are delineating kind of acute and chronic urticaria between the two cases that we've seen. Um, yeah, for this
They can
individual.
last different amounts of time. I mean, some of them are short, some of them last longer. It
Mhm.
can be intermittent, it can be persistent. It's
Mhm.
all over the place. And the first thing that they tell me is he didn't change any soaps or laundry detergents. First of all, if you got the rash, you should change it to see if it makes a difference, but it's useless because those cause contact dermatitis, and this is not contact dermatitis. This is urticaria. So laundry soaps and laundry detergents are irrelevant to hives, but for some reason, everybody always mentions them. I don't know why.
Dr.
Um,
Portnoy, have you seen any contact urticaria with these types of products before?
I used to see contact urticaria when we treated patients with latex allergy.
Mm.
Latex allergy doesn't exist anymore. It's kind of gone away, so I really don't see it anymore.
Mhm.
This, by the way, these are not patient pictures of the real patient. This is obviously an adult, but I was looking for something that showed angioedema. A few days later, this patient developed swelling of the lips and eyes. And since the swelling affected the face, the parents are terrified that her airway will swell and she won't be able to breathe, even though that has not happened. Well, what is this, Dr. Panya? And is she really at risk of not being able to breathe?
So, if she has only presented at this time with swelling of the lips and eyes, and if she doesn't have any additional symptoms concerning like throat tightness, throat pain, difficulty with her speech, change in her speech, or anything like that, at that moment she's not having, any laryngeal involvement or anything like that. And here we don't have any associated symptoms of um, rash, right, or urticaria or anything like that for this particular case?
This is that same patient. She
Oh,
had
this is the same
hives.
patient.
A few days later, she develops this. She had hives,
Okay,
and then she
okay.
developed swelling.
I
And of
apologize.
course,
Okay,
now something
so
more is going
right,
on. Oh my God, she's going to stop breathing. In fact, hives and angioedema go together. This is just angioedema,
right.
and it's
So
not associated with laryngeal edema. There's virtually no risk of not being able to breathe. The only kind of swelling that actually is associated with, death due to not being able to breathe is hereditary angioedema. And she doesn't have that because she has hives, and hereditary angioedema generally is not associated with hives. So does she need epinephrine? No,
no,
absolutely not. But a lot of patients come in already with epinephrine because their primary care doctor decided that they could not be able to breathe, and so they gave them epinephrine to carry anyway. It's not wrong to give epinephrine, but she really doesn't need it.
correct. Yeah.
This is a different patient now. This rash has been present for several weeks. It's persistent, does not move around or change over time. It's only slightly itchy. High dose Zyrtec does not help. A short course of oral steroids does help. What is this?
This does not sound like urticaria to me, Dr. Portnoy. This potentially, by the nature of the picture that we're seeing here, may be a fungal rash. It's one thing that's coming to mind for me. But with regards to urticaria, when we think of, individuals who are having urticaria, the things that we, you know, delineate in terms of the history, when it came on, how long the lesions have lasted for, what are the characteristics of the lesions. Those are kind of the things that help delineate that.
We'll talk about that. I guess my point here is the steroid helped. If it was fungal, it would have made it worse. This patient has a vasculitis urticaria.
That's true.
And vasculitic urticaria is fixed. It's only slightly itchy. Antihistamines do not help. Short course of steroids do help. This is actually very uncommon, but this is what that looks like. This girl gets red raised, very itchy welts every summer. It lasts for several days before scabbing over. The mother reports that she gets very large mosquito bites. Is she allergic to mosquitoes, and should she carry epinephrine?
She certainly can have allergy to the saliva of the mosquito. There's even a term that we have for this called Skeeter syndrome, where people can develop large swelling at the sites of, being bit by a mosquito. However, there is no treatment that we have for it apart from just symptomatic treatment. And then, of course, preventing mosquito bites with insect repellent.
Yeah, and this is
she likely does not need to.
Yeah, this is not associated with anaphylaxis. She does not need epinephrine, but I see a lot of patients who come in with mosquito bites, allergy, and they've been given epinephrine to carry. It's not necessary. So what are hives? Hives are pink. This is the definition. Raised pink erythematous skin lesions that are very itchy. They range from a few millimeters to several centimeters, and they may coalesce into large patches all over the body. This is my favorite word, evanescent. It means that old lesions go and new ones come over 24 hours, leaving no scarring. And when I ask about that and they say they have that, then I just write that hives are evanescent. It's a quicker way to write it. And they can occur anywhere on the body. Angioedema is also associated with hives, and this is just swelling deeper down in the dermis and subdermis. So most often found on the lips, eyelids, and genitalia. I think that's because the skin is looser there. So if you get hives on your lip, you're not really going to get hives. You're just going to get some swelling. Same thing with the eyelids and genitalia. But when parents see this, they freak out. And they come rushing into the emergency room, or they demand an early allergy appointment. And yet this is just the way angioedema presents. It doesn't mean anything bad is happening. It may be itchy. Sometimes it's just painful. It can take longer to resolve once it happens because there's fluid leaking into the interstitial, has to be resorbed. It is associated with hives about 40% of the time. It's pretty common. It's not associated with laryngeal edema. If it's not hereditary angioedema, then you're not at risk of laryngeal edema. And so could they have hereditary angioedema? Probably not, because they have hives. And again, if you have hives and angioedema, you probably don't have, it's not impossible, but you probably don't. So she really doesn't need epinephrine. I keep mentioning the epinephrine because I see so many patients with hives who come in with epinephrine from their primary care doctors. And like I said, it's not wrong, but it's not necessary. And it kind of scares the patients, tells them that something bad could happen. So hives are very common. I mean, pretty much everybody gets hives at some point. This says 15 to 23% of the population. I think it's much higher than that. And 40% of the time, if you have hives, you also have swelling. Sometimes you can have just swelling alone without hives. It kind of varies. You can see the pie chart here. What's the difference between acute and chronic, Dr. Pandya?
The timeline is generally what's different between the two. So if you have urticaria that's lasted longer than 6 weeks, we characterize it as chronic urticaria. Less than that is acute urticaria.
Mm-hmm.
And then in terms, go ahead.
Why do we care?
So it doesn't affect a lot in terms of the immediate management. If you have somebody who has acute urticaria, if you find an identifiable trigger for that, such as a medication, some exposure, a Hymenoptera sting, something like that, then you can tell them to avoid that one thing that caused it. But most cases, even of acute urticaria, are idiopathic. They don't have, a specific thing that caused them. In individuals who have chronic urticaria, but both patients, I should say, both individuals who have acute and chronic, both generally we treat with, a trial of antihistamines to see if it kind of helps their symptoms. So it doesn't necessarily change, what your acute management is going to be at the time period. So yeah, that's kind of what my thoughts are.
I guess I see the differences with acute urticaria. There's a possibility of finding a cause. Personally, I can never find a cause. You just don't. But you can defer testing because the parents aren't so anxious. It's only been going on a few weeks. Once it's been going on more than 6 to 8 weeks, we never find a cause, first of all. And at this point, the parents or the patients are pretty eager to have a test done because after all, it's been going on for so long, there's got to be something wrong. Do a test. They don't know anything about what tests to do, but they want tests done. And the chronic urticaria has been renamed to chronic spontaneous urticaria instead of idiopathic. It was done mainly to keep us on our toes. We got to keep changing things up every so often, but actually it was done because the European terminology was chronic spontaneous urticaria. We called it chronic idiopathic urticaria. We can't have two different names. We better harmonize. So we decided to harmonize on the European title. It's still idiopathic. It just happens spontaneously, which idiopathic also does, as opposed to in response to a physical trigger. I think the difference is there are physical triggers that can trigger urticaria, but if it just happens without any trigger, then it's spontaneous.
And what Dr. Portnoy just mentioned there, at that last point he just mentioned, we can also use the term chronic inducible urticaria in individuals where a physical trigger can cause the urticaria versus, like he said, in spontaneous, where a physical trigger may not induce the urticaria itself.
Yeah, so here are the triggers. So if it's spontaneous, then none of these things have to trigger it. The hives just happen. Physical urticarias can be triggered by, scratching the skin. It's called dermographia. Can put pressure over your shoulders, and then the shoulder swells up. Can get cold-induced urticaria. Aquagenic. I've actually seen one patient who had hives because of water. Aquagenic. It's so bizarre because you tell them that they're allergic to water. It's very weird. Usually it does resolve though, but it's hard to take a shower when every time you get into the water, you break out in hives. And even if it's cold water or hot, the temperature is not the cause. Some people react to the sunlight, different wavelengths of ultraviolet. Cholinergic is mostly heat related. And then vibratory, if you ride a motorcycle, your hands will swell up because of the vibration or something like that. And that first case we showed earlier today of urticarial vasculitis, we always wonder, is this urticarial? But it's actually very uncommon, but it is a possibility. And I guess this slide is here because in patients with acute urticaria, occasionally we can find a cause. The cause is pretty much always a viral infection. Occasionally a food will actually be the cause, but foods only cause hives while you're eating the food. If you eat the food within a few hours of eating the food, you can get hives. If you eat the food and then a week later you get hives, it's not the food. Most of the time it's a viral infection that triggers it.
A lot of times families will say to you that, oh, my kid has had hives for like 2 weeks. It must be something that they're eating. And remember that when we talked in our food allergy lecture, we also have to kind of delineate that in terms of timing of eating the food, onset of symptoms, and resolution. If you're having hives that happen first thing in the morning or hours after eating a food, it's unlikely to be attributed to that. And they have to have exposure to that same food. And so if you're not identifying that in your history, it's unlikely related to that.
Do you find the physical exam to be very helpful most of the time in patients with a history of hives?
Sometimes they come in with the urticaria, with the angioedema. So you observe it in the clinic. You can, upload pictures directly to your electronic medical records. So it's charted in there. But apart from that, if you have somebody who you're evaluating for chronic urticaria, who you're evaluating for dermatographism, you can do this scratch test on their back. But apart from that, there's not a lot of other like physical exam findings you may see. If it's urticarial vasculitis, you may see kind of hyperpigmentation or discoloration at the sites of, where they've previously had urticarial lesions. So if the rash is present, potentially, but a lot of the times they come to you potentially in between episodes. So they may be completely fine or like have nothing on their exam in between those episodes.
Yeah, I always check for dermographia. In fact, if the chief complaint is hives or the parents, remember I only treat kids, the parents mention my child's here because he has hives, I stop them for a second. I don't like to interrupt patients, but I do in this case. And then I immediately explain what I'm doing, and then I scratch the patient's arm with my pen without the ink out, just gently, because dermographia takes a few minutes to develop. And so I do that right at the very beginning of the exam so that by the time I'm finished asking my questions, the dermographia has shown up. You check for dermographia because you're supposed to. Your attending physician will ask you, does this patient have dermographia? First year fellows always say, oh, I forgot to check. And that's okay. We expect you to forget to check. That's fine. But eventually you'll see that it actually is helpful to do it, and then you won't forget to do it. It impresses the parents and patients. You're not allergic to me scratching you, but there's the hives. So it's not really an allergy. And it helps to explain why it's not a food allergy. There was no food in my pen, and I just scratched you and you welted up. Sometimes they just get random dots all over because of when you pick the child up, your fingers will actually induce hives that it's just dermographia from your fingers. Kind of helps me tell a story about what causes hive too. And I have one request. Don't do an allergy skin test if the patient has dermographia. Please don't do that. I've seen patients who came in and everything's positive, but they're not actually allergic to anything. The doctor just did the skin test when the patient had dermographia, and it'll
As
always
a
be positive.
Yeah. And as a reminder, when we do our skin tests, you all remember that we do two controls. We do a saline and a histamine control. If the saline control is positive, that's plain old saline. Nobody should react to that. But if they are developing a urticarial lesion, as Dr. Portnoy mentioned, just to saline, that means that the entire skin test can be falsely positive and it's not appropriately interpretable at that point. Limited utility there.
Yeah, but some doctors are so eager to have positive tests that they kind of overlook that. I'm not saying that anyone listening to this would ever do such a thing, but it does happen. So personally, I find hives to be difficult. When I first started telling patients about their hives and what was going on, of course, we don't know why they have the hives. The parents would get upset because you're not answering my question. You need to do more tests. What's wrong with you? Why can't you tell me why my child has hives? And parents would get angry. They would get upset because you're not answering. So you're not satisfying them. They have expectations of what they want to get out of the visit, and they don't get it. Over the years, though, I've kind of learned how to explain hives to parents and patients so that they kind of understand it, and then they don't get upset when you don't tell them exactly what the cause is. So here's what I tell them. This is a script, and you can write it down and actually use it. I tell them that hives are very common. Almost everyone gets them at some time. Hives are not caused by allergies, including foods. They're usually surprised at that because they fully expected I was going to do a huge panel of foods. Testing doesn't help. They generally do not mean that anything bad has happened. The parents are afraid that their child has cancer or some kind of arthritis or autoimmune disease or other things. And they don't even know what they think there is. They can imagine just horrible things, and the hives is a sign that that's happening. I reassure them it does not mean that anything bad is happening. I tell them that hives are caused by activated mast cells. I I tell them that you have mast cells in your skin, they have histamine, they become activated, they release histamine when they're stimulated. And if I've done my dermography thing, I can show them, look, see, the mast cells are releasing it right now as we speak. It kind of illustrates that what I'm saying is correct, and it impresses them. I also tell them that eventually the mast cells will deactivate and the hives will just go away on their own. We can't speed that process up. I don't know how to deactivate them. So all we can really do now is to manage the hives while we wait for the mast cells to deactivate. Since it's a histamine release problem, then the treatment involves antihistamines. I also assure them that it often takes a higher dose than hay fever doses to control the hives. They've usually been on something that was like one tablet of Zyrtec once a day, and that didn't control the hives. Well, it's because that's the hay fever dose. Hives take higher dose, sometimes as much as 2 tablets twice a day. You may need to quadruple the dose. That's why you want to use non-sedating antihistamines like Zyrtec or Allegra or something like that, as opposed to Benadryl, because Benadryl, you can't increase the dose very high because of the side effects. It's also a pretty weak antihistamines. And do you have a different approach to explaining it, or what do you think about this?
I think I use a lot of overlap of everything that's identified here. I think a couple other things that I do is, especially if they have, chronic urticaria, I tell them your child has a diagnosis of chronic spontaneous urticaria. Oftentimes, just having a diagnosis, they like to have a name, that they can kind of associate with what's going on. And in addition to that, mentioning a lot of the things that Dr. Portnoy has mentioned here, like it goes away on its own. Another thing that they often want to know is, are they at risk for future systemic reactions? And the answer to that is no. We mentioned at the beginning of the presentation, these patients don't need to carry an epinephrine autoinjector. So oftentimes, and they may have seen this either through the media or heard about this, with other practitioners, that, if you're getting hives and swellings, you're going to get full body reactions, and it's definitely something you're doing that's causing it. And so they come to you with all of these fears, and in reality, it's just something that the body has spontaneously developed. And as spontaneously as it's developed it can resolve in that same fashion. And we have medications in our arsenal that can symptomatically get us under pretty good control.
Precisely. Oh, sometimes it's helpful to figure out, or at least to monitor how bad the hives are, because if you're going to treat them, you want to know if the treatment helped, and it would be nice to quantify that.
Mm-hmm.
Do you ever do a UAS 7 score?
Absolutely. I can talk through the scoring system. So
Yeah.
the UAS 7 evaluates or asks 2 main questions. One, how often or how many, I should say, in a day has the patient had hives? And so you can kind of see under the wheels score, under the chart column, there's no wheels, mild is less than 20, moderate is 20 to 50, and then intense is greater than 50. And then if you go to the right hand, it says the itching score too. Now, individuals with chronic urticaria can have pruritus in the absence of rash. So it's important to monitor both of these things, especially as you're monitoring them long term. So you get a number here, but remember that this is just a number for a day, and then you have to multiply it by 7 as it tracks 7 days of the week. So then you get a 7-day score. And so, yeah, I definitely use this in patients who have chronic urticaria, and then kind of jumping not too much forward, but oftentimes if you need to do advanced treatments on these patients, such as consideration of biologics, this is often needed in order to get those approved.
Yeah, the health plans sometimes want the UAS 7 score, and they certainly want to know if it got better, because is the biologic working or not? It's nice to have a number.
Yeah.
And you can see that, well, it can be categorized in terms of no hives all the way up to severe, and it has been validated, so it's a valid system. Okay, so now this is what everybody wants. What do we do? How do we treat hives? What works? And this is my opinion, but Zyrtec and Allegra, I believe, are the most effective antihistamines for hives. They're relatively inexpensive. You can quadruple the dose if you need to, because they really have minimal side effects. The limiting factor for Zyrtec is sedation. I don't think Allegra is even sedating at all. Claritin does work, but it's not as effective as Zyrtec or Allegra, and there's a variety of reasons for that we're not going to go into. You can use Claritin, it's just not as effective. I don't recommend Benadryl. It's not recommended because it's a relatively weak antihistamine. It does have side effects, it knocks you out, and that limits the dose. Some people will also add an H2 antihistamine. I see that pretty commonly. You can do that. Usually doesn't help, but it doesn't hurt.
And then a couple other things I can add here. Oh, it's on the next slide. Never mind.
There you go. Yeah. Why don't you do this?
Yeah. So the next question that always comes up is, do we need systemic steroids either on a daily basis or do we need them intermittently? While they can help with, preventing the hives or even stopping the episodes of hives, this is not a treatment that is effective long-term or that we should be doing long-term because there's so many other side effects that are associated with systemic steroids. And we have a lot of other medications in our arsenal that we can use to help these patients. And then, so doxepin. So this is a tricyclic antidepressant. It does have H1 properties in it, which is why it's been used in the past for chronic urticaria. It's very sedating, and higher doses, you do have to monitor for QT prolongation. In that same token, hydroxyzine is another, medicine that is a first generation H1 blocker. And you can use it at higher doses, 25, 50, 7,500 milligrams. I do find sedation in my personal practice to be a big limitation with both hydroxyzine and doxepin. And I think that has been recognized so much so that even in recent treatment algorithms, these have not been included as agents. Now, whether insurance companies require it is a different question, but in terms of the treatment algorithm for chronic urticaria, these have kind of fallen out of favor as a result.
Yeah, just a word about hydroxyzine. When you take hydroxyzine, your liver converts it into cetirizine. So Zyrtec is the metabolite of hydroxyzine. So they're basically both the same thing. Hydroxyzine is just a more sedating version of cetirizine. So I don't usually use hydroxyzine unless I want this sedation. Doxepin is very sedating. Just anecdotally, my wife had hives a number of years ago, and they didn't respond to the antihistamine, so we tried doxepin. She took one dose, and about 2 days later, she finally woke up.
Oh my gosh.
She was very sensitive to
Wow.
it, but she obviously could not tolerate it because of the sedation, and most of my patients really can't. But I have had some health plans require a trial of this before they will approve a biologic, just because they really don't want to pay for a biologic.
Yeah.
Let's see here. Here's some other treatments. Now, I mention these treatments to my patients when I talk to them about cetirizine and doxepin and so on, not because I expect that I'm going to need to use them, but because I want to show them that it would be really nice if the cetirizine worked, and don't be dissatisfied if it doesn't work completely and say, I want something else because the other things are not as good. You really don't want these things, but there are other things that can be used if you just absolutely don't respond to the antihistamine treatments. And here are some that have been shown to be effective for hives. They all take about 6 to 12 weeks before you see an improvement. My guess is it's hard to tell whether there's actually an improvement or whether the hives just went away on their own. Some of these do have double-blind studies, so we know that, but some of them really don't. They're not very well characterized for the treatment of hives, and they all have significant side effects. Do you ever use any of these for your hives patients?
So I have used them. I don't routinely use them. So there are a few individuals I can think of where there were some limitations with biologics, or we weren't able to escalate, doses of biologics where we had to use hydroxychloroquine as well as dapsone. As Dr. Portnoy mentioned, those can take a little bit of a time some weeks to see effect. Cyclosporin, however, the last one that's listed here, you could potentially see some benefits much sooner with that particular agent. But remember that both methotrexate and cyclosporin are systemic immunosuppression. So they do carry significant side effects that need to be monitored, and that includes potentially getting lab work frequently on the patients. We know that cyclosporin is very effective. In fact, if you fail biologic therapy, it's still a treatment that's in your arsenal for urticaria. However, with the different dosing that's available for one of the biologics that we'll talk about, as well as potentially a second one, hopefully coming on the market soon for chronic urticaria, I think use of cyclosporin has decreased, but it's still a treatment in our arsenal we could use if we needed.
Yeah, it's also been used for atopic dermatitis. I would mention that hydroxychloroquine has not been shown to be an effective treatment for COVID. Okay, biologics. This has really changed everything. And it's mostly omalizumab or Xolair. I'd say it's replaced most of the other treatment options past antihistamine and doxepin. It's usually highly effective. I've seen patients really respond pretty well to it. It has very few side effects. It's pretty safe. Patients can give it by injection at home. The downside is, of course, you need to get prior authorization because it's very expensive. Health plans will almost always deny initial requests. Then you'll have to appeal and send in letters of necessity, and they might deny it again, and you might need to do a peer-to-peer. That's why getting a UAS7 and really documenting it and trying the doxepin before you apply for the omalizumab is helpful. But if you persist, you can usually get it approved. And like Dr. Pandya mentioned, other biologics are being studied, maybe available soon. I don't really know much about those. I usually don't bother to learn about them until I can use them.
Couple points to mention about omalizumab. So this is approved at 12 years of age and above for chronic urticaria. And so it's not that it hasn't been used in younger ages for individuals who have this diagnosis, but in terms of currently what it's approved at, that's one thing to kind of note here. And then the second thing is, when you're starting your patients on, I think we talked about this in a previous talk, just counseling them about any potential side effects. But overall, it's a pretty safe drug. And, we've even moved to home injections of this medication as well. So.
Exactly. So this is the sequence that I use when I'm treating hives. So if you have a patient with hives, go through the sequence. First thing, make a diagnosis. The next thing, convince parents and patients that testing is not needed or helpful. That's much more difficult than making a diagnosis, and sometimes you might have to just give in and do the testing. Trial of an H1 antihistamine at a dose high enough to control the hives. It usually requires a higher dose than hay fever doses. You can go up to quadrupling the dose if necessary. Usually during this part, the hives will resolve because they will eventually resolve, and it takes time to do this. If the antihistamines don't work and the hives haven't resolved, then I go right into a trial of doxepin, and I usually don't go above 25 milligrams. That's enough to knock anybody out, and you don't have to worry about cardiac arrhythmias, which I don't want to deal with. If that doesn't work, or if it's not tolerated, usually because they're just knocked out, then I immediately start the prior authorization for omalizumab. Sometimes if the hives seem really bad and the patient's utterly miserable, I will start the prior authorization before they try the doxepin, and I'll just write that they tried it and it was too sedating or something. I'm not lying, because by the time it goes through, they will have tried it and I'll know the answer. This is the reality. You will need to fill out many forms. You will need to write appeal letters, peer-to-peer, or peer. But with persistence, you can get it approved. I know you can do it. If Xolair doesn't work, and I've had a small number of patients who did not respond to Xolair, then a trial of alternate treatments one at a time sequentially is the next step. It gives you at least 6 more months for the hives to resolve on their own, which eventually they do, and that's what you're really waiting for. Do you any other ideas about this?
Yeah, a couple other points to mention. So the dosing for omalizumab with individuals who have chronic urticaria, we have two dosing options: 150 milligrams every 4 weeks or 300 milligrams every 4 weeks. And so those two dosing options are available. There are studies that look at dosing omalizumab at every 2 week interval for chronic urticaria, essentially with higher doses. And there's potentially a subset of patients that may respond to that. So that's one other thing you can think about if they're not responding to standard dosing of omalizumab. That is not yet recognized, as a FDA dose for that patient. So again, it's kind of an off-label thing that can be done, but there, like I said, there is some data suggesting that that can work. But then if you're hitting a limit with that, and then also when you're hitting a limit, you may need to wait 3 to 6 months to see a true benefit from the omalizumab. So making sure you're giving your patients a realistic timeline of when you're going to see a benefit from the omalizumab. And then if you're
Doesn't it
not,
seem to work faster than that most of the time, though?
yeah, if we get to see that, it's awesome, because then the families start experiencing, and that's true, actually. I say this time interval. However, some patients may experience benefit within the first 2 doses of omalizumab. So it's certainly possible that they can experience this benefit sooner rather than in that longer time interval. But if you've had a long time interval with omalizumab and they're still not having improvement with symptoms, it's reasonable then to consider alternative therapies.
Yeah. And, you mentioned the 2 doses, 150 and 300. I always start with the 300. If you start with the 150 and they don't respond and you want to move them up to the 300, you have to do the prior authorization all over again. It's not worth
Yeah.
it. If they respond to the 300 and they want to try going down to the 150, it's a lot easier. Just some practical things.
Right.
So what about tests?
What about tests? This is always a question that comes in. What allergy testing do I need to do? And there have been multiple consensus statements in our practice parameters released saying that broad aeroallergen and food allergen testing is not beneficial for these patients. And the big thing is, even if they come to you demanding a test, let's say they're like, I absolutely need to get this test done. Once you explain this entire thing to the family, you can tell them, even if I do the test, it's ultimately not going to help your kiddo, or it's not going to help you if you're talking to an adult. And so it's doing a test where you can make, let's say, the money off of the test, but it doesn't give the patient any additional guidance on what they need to do practically and an answer as to why they're having it. So it's kind of not, it would kind of be a waste for them to have to get that done.
Yeah, but the parents will start to get anxious after 6 months and they'll start demanding tests. So at some point you might be forced to do a test. What tests should you do? Well, as Dr. Pandya said, since tests don't help, it really doesn't matter what test you order, just order something. Buys you 6 more months for the hives to hopefully go away, because at least you did tests. 6 months later, they might want more tests. I don't know. It doesn't usually come to that.
Exactly. And to delineate, I think this pops up on a later slide, but
these are the tests.
Exactly, right here.
Are there any that you actually commonly do? Do you do all of them, or which are your favorite tests?
Yeah, exactly. So why is this even coming up? Did we pick these tests out of random? Where did these specific lab tests come from? So these have kind of come from, again, practice parameters where we've evaluated or where patients who've had chronic urticaria have undergone these tests. And so some of these tests are looking at associated diseases. So your CBC with diff, SED rate, CRP is looking at associated diseases. Jumping a little further where it says thyroid testing. So we know that autoimmune thyroid disease and chronic urticaria can occur, in conjunction with each other. And the reason for that is because chronic urticaria, spontaneous urticaria, is being the pathology of it is studied pretty extensively, and there could be some autoimmune phenomenon that is, triggering this particular disease. We know that autoimmune diseases tend to occur together, which is why we've seen this association of autoimmune thyroid disease in patients who have chronic urticaria. However, multiple articles about this have shown that treatment of the thyroid disease does not result in remission of the urticaria. So making sure your patients have a realistic expectation of that as well. And then going back up here, so IgE panels, that's kind of what we were talking about on the last couple of slides here. While you can do aeroallergen testing, it's not really going to give you an etiology of their chronic urticaria. And the same thing, if you don't have a history consistent with an IgE-mediated food allergy, it's really not going to be helpful for chronic urticaria. And in fact, as we talked about in our diagnostic testing lecture, you could end up with a false positive. And then you have to deal with, what do I do then with the food going forward? So there is some potential risk of doing food IgE testing in these individuals. And then lastly, liver and kidney tests, so LFTs, and kind of, looking at a basic metabolic profile. Essentially, you are also looking for, associated, autoimmune diseases that affect these organs, which is why they've been done. You also have some types of hepatitis, especially like in the past, you've seen viral hepatitis C or hepatitis that can result in having urticaria. So that's why these have been done before. But generally, like I said, you're looking for associated diseases, but it's not going to tell you any additional information about the urticaria. And then skin biopsies, the very last point here, is indicated if you have a clinical history consistent with a vasculitis, like an urticarial vasculitis. But for chronic urticaria itself, if your lesions are resolving within 24 hours, if they're not leaving any discoloration, scarring upon resolution, really there's not a strong indication to do a skin biopsy at that point. So that's why these tests have been identified in practice parameters potentially as ones that can be done apart from the food and aeroallergen testing.
Do you ever measure chronic urticaria index?
Oh, I'm sorry. Yes, I completely forgot that. So chronic urticaria index panel. So we're essentially measuring IgG to a IgE antibody or receptor antibody. Fc epsilon receptor, and seeing if we have that present. So they've looked at this so much in terms of does this differentiate prognosis in individuals who have chronic urticaria? Does it affect the treatment that you do? Are these individuals more likely to benefit from biologic versus not? And there has not been any conclusive kind of recommendations that have come from that particular test. But that's certainly an area of interest that has been studied. And yes, I have done the chronic urticaria index.
Yeah, that's one that I usually do, because if it's positive, you can say, hey, you have an urticaria, autoimmune urticaria. And then they're like, oh, wow, they've got a name to give to it now. It doesn't change the treatment, but somehow it's satisfying to know that you've got a cause.
Yeah.
What about angioedema? Because this is something that scares parents to death, even though especially if it's on the face. They believe, like I said before, it's going to lead to airway blockage and death. And the anxiety can actually trigger vocal cord dysfunction and make it hard for them to breathe. They will actually have trouble breathing when they get angioedema because they're so scared.
Yeah.
Although it absolutely does not lead to laryngeal edema. It's common among adolescent girls. I think there's some hormonal issues involved. I've seen adolescent girls who actually cycle and they have hives with their periods. Usually swelling. It lasts for about 6 months, and then eventually it stops happening. It always stops eventually, but the treatments that we normally use, like antihistamines and Xolair, don't work for this very well. And as a result, the parents and the patient will call you frequently. You'll get numerous calls asking for advice when the treatment fails. It will make your life miserable. If you see an adolescent girl with this condition, your life is going to be very unpleasant for the next 6 months. I'm sorry, I'm not trying to be flippant or anything. It's just a fact, because nothing works, but eventually it will stop. It never is fatal, but it's very disfiguring. Their face swells while they're in middle school, and kind of doesn't look good, and they're very self-conscious anyway. I have actually anecdotally had success with tranexamic acid. It's weird. It's a fibrinolytic that's used to stop heavy menstrual periods, and it has been shown to be like the other alternate treatments can be effective for angioedema. And for adolescent girls, I've found this to be helpful occasionally. What do you tell people? What do you have you seen this?
Yeah, I think when you're evaluating angioedema like this, one of the things that, especially as a fellow, that you're thinking about is which category do I put this patient in? Are they likely to have a histaminergic urticaria, or is it more likely to be a bradykinin-mediated angioedema? If it's a histaminergic angioedema, the angioedema episodes will typically be shorter. They'll last less than 72 hours. They'll be associated with pruritus. You can have associated urticaria in those individuals, and they can respond to antihistamines, steroids, etc. With bradykinin-mediated angioedema, the episodes are going to last longer. They're typically going to last longer than 3 to 5 days. And then they generally don't respond to, antihistamines, to steroids. And so, there is some testing that you can do for someone who's having bradykinin-mediated angioedema that's different than histaminergic angioedema. And then which advanced therapy you go to is a little bit different as well, depending on which category the patient falls best into.
Yeah, I mean, the bradykinin, when you're really talking about hereditary angioedema, HAE, if it's not HAE, there are idiopathic forms of bradykinin-induced angioedema, but HAE is the most common one. And when I see a patient who's been having angioedema and they're referred to me, it's almost always to ask does this patient have HAE, hereditary angioedema? That's usually what the referring doctor is asking, because they just don't know and they're afraid of it. So here are some tips that will help you to rule out hereditary angioedema, because that you will see them. Usually it's not associated with hives. I mean, hives doesn't rule it out completely, but it's not known to be associated. It's usually just pure angioedema. There's almost always a family history. If somebody comes in wanting to know if they have hereditary angioedema, the first thing I ask is, well, who else in the family has it? It's almost always somebody, because it's autosomal dominant. Episodes don't start before puberty. If you see a 5-year-old and they're having swelling, that's not HAE. 5-year-olds usually aren't having episodes. It doesn't start till puberty. They, like Dr. Pandya said, they start with a burning sensation. It comes on slowly over several days. It lasts for a while, and then it slowly resolves. So it's a much slower process than histamine-induced angioedema. Antihistamines and epinephrine, most importantly, do not help for HAE. Epinephrine doesn't work if you're having a hereditary angioedema episode. To screen for it, you can look for C4. It can be used for screening, particularly if they're having an episode. Between episodes, the C4 isn't always low, but during an episode, it's always low. A slightly low C4 does not prove that it's HAE. It just suggests that maybe it could be, and you need to go further. And the further that you would go is to do a C1 esterase inhibitor level. It can either be functional or antigenic. Personally, I just do those when I do the C4, because if you do the C4 and it's low and then you have to do another test, they have to come back, and it's better to just do the whole thing at once. These may be low in patients who don't have HAE, partly because the test is the functional is very labile. It can, if it's not processed properly, it can decay and give a false low. So you should always repeat a low value just to convince yourself that it's real and not due to lab error artifact. If both values are normal or they're high, the patient does not have HAE. And I really emphasize that because anecdotally, I had one patient who their whole life they were told, you have HAE, it's very dangerous. They had letters, it was a real problem, and the parents were convinced that their child had this horrible disease. But the C1 esterase inhibitor levels were always normal or elevated. They were never low. The patient did not have C1 esterase inhibitor levels, but occasionally the C4 would be low, probably because the patient may have had an autoimmune disease, which can also make your C4 get low. And so the parents did not believe me when I told them that they don't have it, because they'd lived their whole lives believing that she does. Don't diagnose somebody with HAE if they don't have it.
And a couple of other points, if I can mention that real quick about angioedema. So in our population that we treat for kids, this is more, it's rare, but still something to think about. Medications can cause bradykinin-induced angioedema. ACE inhibitors, ARBs, there's certain diabetes drugs too, and our pediatric patients do come to us on these drugs. We also, of course, know that these medications are widely prescribed in the adult population. So if you're having someone who has episodes consistent with a bradykinin-mediated angioedema, the first thing you're going to want to do is look at their drug list and see, is there a likely offending agent that's causing it? You can have pretty prominent laryngeal edema in those individuals. I've seen one of the most significant cases in my life due to a ACE inhibitor. And the second thing is, if you have a strong suspicion that someone is having a bradykinin-mediated angioedema, and ultimately their C4 testing is normal, their C1 esterase testing is normal. By the way, there's also a C1q testing we can do if you're concerned that the patient has an acquired angioedema, which can be secondary to another condition, secondary to a malignancy or an autoimmune disease. But if you rule even those out, there are some genetic tests, as well, that we can do for these patients. We mentioned that vignette of someone in a young female going through that. So we know that factor 12 deficiency mutations can cause bradykinin-mediated angioedema. And it happens right around the time that hormones change in the patients as estrogen and progesterone fluctuates. So if you get to a point where, medications have been ruled out, this testing has been normal, you've done a C1q, there are some genetic tests that you can look at for acquired angioedema, depending on how high your pre-test probability is for those patients.
Well, there we go, that pretest
Had to
probability.
plug that back in from our other
Thank you.
lecture.
So I guess just to summarize, because we're almost at the end, most hives are idiopathic. We're idiots about the pathos. We don't know the cause. They can be spontaneous, or there may be specific triggers. I don't really find the difference to be very helpful. Just because there's different triggers doesn't mean it's a different disease. Identifying the trigger doesn't really help, in fact, unless you can avoid the trigger. This is just my own personal feelings about this. Most hives eventually will go away, regardless of treatment. Hives are not associated with underlying bad disease most of the time. Now, in adults, there are cases of malignancy, hepatitis, autoimmune disorders that can cause hives. They're uncommon, but they do occur. So I'm not saying it never happens. I'm just saying most likely. And if your treatment of hives doesn't work, then you can start maybe looking for these other things. But really, I don't know about adults. I only treat kids. Do you find these things in your adult patients very often?
In terms of those others. So, we're even seeing some complex kids who, I've seen incidences of bradykinin-mediated angioedema or something else going on. It is rare, like you're saying. And in adults, I've certainly seen it definitely, occur.
Yeah, I just treat kids. Testing is rarely helpful. It's almost always requested by anxious parents. Sometimes it may be best to just simply do some tests to keep them happy. I don't care which tests you do, just do a few. Treatments with H1 antihistamines, Zyrtec and Allegra are my personal favorites, possibly Claritin. I'm using brand names, by the way. This is not CME. I can use whatever brand names I want, usually at 2 to 4 times the normal hay fever dose. H2 blockers and steroids are not effective for long-term control of hives. I never prescribe those. Refractory hives usually improve with omalizumab, so that's my next go-to step. If that doesn't work, there are these other treatments that have more toxicity and variable efficacy, and I just start down the path, one right after another. The most important thing is really just to listen to and acknowledge the concerns that the patients and parents have, because they're usually very anxious, they're very upset. It's really affecting their lives. Just being a sympathetic ear and listening to them, probably the most important thing you can do. Any final words, Dr. Panya?
No, I think that's covers everything.
Okay, well, then we're going to turn it back over to Dr. Miller, and he can lead and see if there's any questions.
All right. Thank you. A nice presentation. Let's open this to the live audience today.
Hey, I have a quick question. So, of course, like you always want to kind of rule out the big bad monster, like in something like this, which is like a urticaria, like vasculitis. Of course, to delineate, like you have your common stuff, like the time course, the burning, and the bruising. Have y'all ever seen this clinically? And if y'all have, like, did the patient present with anything else and any additional lab work? I mean, I know like the overall thing is you got to get them to derm and do a biopsy, but just seeing how those patients presented and and kind of what that looked like more clinically, because I feel like that's something you don't want to kind of miss.
Yeah, great question, Dr. Etta. So I'm going to answer that in twofold. Yes, I have seen patients with urticarial vasculitis, and there's two types and I think this is going to come up later in your COLA series, so I won't waste too much time talking about this, but you have a hypocomplementemic urticarial vasculitis, which is going to be associated with systemic manifestations. You're going to have liver, kidney involvement, lots of different organs that are involved. And then urticarial vasculitis, which is largely just, skin involvement. And generally the things that I've seen with both of those, presentations has been the duration of the urticaria, and largely you have these discoloration areas that happen kind of even alongside. So I've seen individuals who have like hives, and then they have these other areas of discoloration where they previously had urticarial looking lesions, and they kind of look like they're scarring in those areas. So having that kind of symptom morphology outside of the normal of urticaria is why it's so important to ask those questions and do a skin exam on those patients.
That makes sense. Appreciate it.
Yeah, good question.
All right, any other questions? Okay, let's take a couple minute break so everybody can stretch and take care of themselves, and then we'll start with the next presentation on telemedicine.